We have to move on. Now, next speaker will be Dr. Guillermo Ruiz-Argüelles. He will have a talk on autologous transplant for multiple sclerosis, the Mexican experience. Thank you very much. You can start.
Thank you very much. First of all, I would like to thank the organizers of this meeting for inviting me to present our experience. I am talking on behalf of my group of work in HCT Mexico. I do not have any conflicts of interest, and it has been said HCT in MS is the best treatment. There are several schedules to conduct the transplant. Most of them employ high-dose cyclophosphamide, which I feel is the most important part of the transplant, 200 milligrams per kilo. And then some of them use ATG, rituximab, fludarabine, and some of them are done on an outpatient basis, whereas others are done in hospitals. This picture here refers to the progression-free survival in persons with multiple sclerosis treated with several types of treatments. It is clear from this picture that HCT programs are substantially better than other drugs, at least in what has been published up to now. I am going to present our experience in clinical risk located in Puebla, Mexico. We have done 2,376 transplants between 1993 and this year. And by March this year, we have done 2,376 transplants, most of them autologous and some allogeneic. The main indication for autologous transplant is, as is clear in the picture, multiple sclerosis. And I will refer to this experience in clinical risk HCT for multiple sclerosis. Between 2015 and 2026, we have grafted 1,936 persons with multiple sclerosis. We conducted transplant on an outpatient basis. We employ non-frozen hematopoietic stem cells. We employ cyclophosphamide, 200 milligrams per kilo, divided in 4 doses, 2 blocks apart. And at the end of the transplant, we employ rituximab. This picture here refers to schedules that are employed in several parts of the world, in Russia, Chicago, and in Mexico. In Russia, fludarabine is employed, whereas Chicago employs ATG. We do not employ ATG. We employ at the end of the transplant rituximab, and the 4 doses of cyclophosphamide, 50 milligrams per kilo, are divided in 2 blocks apart, and this is a salient feature of our method. We have registered our method in this website, so anybody can reproduce it. And as I said, we have grafted 1,936 patients. Granulocyte recovery occurs in around 7 days, platelet recovery in 5 days. We have been able to conduct the transplant fully as outpatients in 97% of persons, and we can do it as outpatient. And the fatality rate is 0.2%. The response rate is around 80%. Patients to our clinic have come from different parts of the world. As you can see, the largest number of persons come from the United States, then from the United Kingdom, the Netherlands, Canada, Norway, and some other countries. We take this very seriously. We have published our experience since we started doing this. Initially, we published this feasibility study to prove that we could do it on an outpatient basis. This is a safety study published later on, and this one reports to the efficacy of our method, which, as I said, efficacy is around 80%. The results are better in relapsing remitting multiple sclerosis, as it is shown in the picture, and the results are better 18 months after the transplant. We have gained some and learned some lessons by doing this. We have published this experience as well. This paper was published when we did the transplant number 1000. And recently we published data on early mortality in autologous transplants in a group of 1,700 patients. These are the 100-day complication rates in clinical risk. As you can see, the results are similar or probably lower than those found and reported from other centers. And in some cases, this results in admitting the patient to the hospital. Only 3% in our experience. We recently published this paper on innovations in hematopoietic stem cell transplants in low and middle income countries, and we report there a group of 1,910 patients with autoimmune diseases. How these data compare with what is happening around the world? Well, this paper here refers to 4,831 patients. It was published in 2022. And the numbers of the patients published by then appear in the slide. And in England, as it has already been shown, the British Society of Blood and Marrow Transplantation and Cellular Therapy published their experience, a 20-year experience, and I was asked to provide a comment on that particular paper, and it was a very interesting occasion to establish some comparison. The salient comments that I made in that particular paper is that the experience in the United Kingdom refers to 364 patients. Ours is larger. As in England, we have found that HCT works in all types of multiple sclerosis. There was the idea that it worked only in relapsing remitting multiple sclerosis, but this has shown to be not completely true. Better results are obtained in relapsing remitting multiple sclerosis. Mortality in the United Kingdom, as Professor Munaro has said, was 1.4%, and in our experience was less than that, 0.2%. And the complication rate was the most salient complication was viral reactivation. And I feel that this stems from the fact that they employ ATG, whereas in other groups, ATG is not employed. I honestly feel that the main job is done by the cyclophosphamide and not by other drugs. Now, this experience has led us to improve our way of conducting transplants. We have finished step 1 of this FACT-JC accreditation, and very recently, some days ago, we obtained the certification by FACT-JC related to the second step. So this program has led us to improve our way to conduct transplant, and I feel that this type of certification is very important. We have also shown that splitting the doses of cyclophosphamide the way we do it results in less cardiotoxicity and also in less nephrotoxicity, and it seems to be related also to the low mortality rate. We have also shown that our results are better in persons that have not been exposed to previous disease-modifying therapies. So it is possible, this has not been shown, that HCT could be the first treatment option for these persons. We have also published our experience on why are persons with multiple sclerosis traveling to Mexico, specifically to Puebla and Monterrey, with Dr. Gomez Almaguer, who is here. And there are several reasons to explain why they are going there. We have also shown that the number of CD34 cells is not related to the outcome, which is logical. I mean, this is not a stem cell treatment, this is only chemotherapy. And we have also shown that patients that have an early response during the transplant are those that do better on the long term. So, in conclusion, HCT for multiple sclerosis in clinical risk seems to be by now the largest worldwide experience. We have grafted almost 2,000 patients. We employ non-frozen cells, and this renders a substantial decrease in the costs. We do the transplants on outpatient conduction most of the time, specifically 97%. We employ cyclophosphamide, 200 milligrams per kilo, and rituximab. We have lower morbidity as compared with that depicted in some other part of the world, and our mortality rate is very low, 0.2%. HCT for multiple sclerosis in general, not only in Mexico, has now a large worldwide experience. HCT is better than drugs. This has been shown in several studies, as Professor Muraro already showed. The response rate of HCT is around 80%, whereas that of drugs is around 50%. HCT is cheaper than drugs. This is very clear. HCT is safe by now. This has turned a safe procedure. And the critical point in HCT, I feel, is cyclophosphamide, 200 milligrams per kilo. And I don't know the usefulness of rituximab, ATG, fludarabine. I feel that the main point here is cyclophosphamide. This is a picture of my family to whom I dedicate this lecture. They have very supportive of all these studies and travels and so on. And I am indebted to them. My data, if some information is to be provided. Thank you very much.